Hi, it's my pleasure to provide you an update with our current projects that we're involved in at the Indiana Center for Vascular Biology and Medicine, in which we are working hard to change the course of vascular disease and the many diseases in the body that are directly affected by vascular disease. We very much would like to thank you in an ongoing way, as we always do, for the tremendous support that you have provided us from the CMMRF over the many years that we've been working together in partnership. As many of you may have seen, 2 or 3 years ago we came up with this mnemonic, this list of some key areas that we're focused on, and put them together in an acronym, HELPS for All. This refers to heart, eyes, legs, pancreas, stroke, arthritis, lungs, and little people even, to refer to some pediatric diseases that we're working towards. And in the topic of pancreas, I would include both diabetes, which of course is a problem largely rooted in the pancreas and the beta cells that secrete insulin within the pancreas, as well as pancreatitis, another key problem disease area that we're focused on moving from the laboratory studies into patient care, and I'll cover that in a little while. The Indiana Center for Vascular Biology and Medicine has had the opportunity to generate some new programs in the last year and also to continue prior programs that have been very productive for us. As you see here on the slide, the National Institutes of Health is the key supporter of the CCTRN, which refers to the Cardiovascular Cell Therapy Research Network, that we're extremely thankful, privileged to be one of the 7 members in the country who are participating in that network. That network involves the clinical trial of cell therapy to treat cardiac and vascular diseases. And the clinical trials that thus far have been supported with that network include a trial involving legs, that is with people who have severe peripheral vascular disease, so severe in fact that it creates a problem for their circulation and pain in their legs, essentially what you might call angina of the legs when they walk. Not so severe that it causes the need for an amputation, but if allowed to progress, could in fact go in that direction. And that is the target of our first clinical trial that's been supported by the NIH CCTRN, Cardiovascular Cell Therapy Research Network. We will also soon be working in the area of heart failure in 2 types of trials, one involving heart attack resulting in heart failure as a consequence of poor blood circulation, and the other involving chemotherapy that causes heart failure as a consequence of particular types of chemotherapy. Those that involve something called anthracyclines, one of which is adriamycin. It's typically a very red-looking intravenous agent that's dripped into the arm through an intravenous needle. And this red chemotherapy agent is often used for either sarcomas or breast cancer, and unfortunately has a significant proportion of people who can receive it, depending on the other treatments that they also receive, that will encounter heart failure as a result of that agent. And so we are also going to be looking at if we can treat and limit the degree or ameliorate that heart failure that is caused by that particular therapy. Also supported by the National Institutes of Health is a training program in vascular biology and medicine. We're very grateful to have had the honor of training 18 trainees to date over the last period of time that program has been supported, the prior 9 to 10 years until now, specifically supported by that program. We're training investigators who are both PhDs and MDs to go out and conduct vascular biology work in other centers as well as in our center here. And that also, as with many of our programs, leverages importantly the philanthropic support that we've been able to obtain from your key support, but building on that support with NIH, with foundations, with other areas. These are how we leverage and build from the foundational support that our philanthropy has been able to help us with. We've also started in the past year another first in the USA. That is the first trial that was approved by the FDA to treat legs with one's own fat-derived stem cells in order to avoid an amputation. We also are pursuing new animal experiments in several areas, which include pancreatitis, kidney failure, and even heart transplantation. We are also in the process of planning for clinical trials in some new areas. Arthritis of aging, or osteoarthritis, and we've just recently received an FDA approval to proceed with that trial. Arthritis in children, in particular called rheumatoid arthritis, or something also called pediatric idiopathic arthritis, which is often related to an autoimmune type disease. Diabetes, as I mentioned earlier, and pancreatitis. Retinopathy, that means the problem with the retina in the eyes that's often due to diabetes. Emphysema, the problem with the lungs that's caused often as a consequence of smoking. Even erectile dysfunction and stroke. And in each one of these areas, we're working to obtain funding for the clinical trials that need to occur. Looking just a little bit in more detail at the CCTRN, the Cardiovascular Cell Therapy Research Network, as I mentioned earlier, we're very grateful to be one of the only 7 centers across the country that was selected in 2012 as the very best centers to work together in moving cardiovascular cell therapies from the bench to the bedside. And as you can see, we mark here on the map the 7 locations. The program has been funded for a 7-year period, and as I indicated, we've just been in the process of testing cells to reduce pain due to poor circulation in the legs. And we are now testing, soon to begin testing cells from one's own bone marrow and one's own heart, in fact, by a little tiny biopsy that will take a sample of the heart and grow those what's called heart progenitor or stem cells out and test the effect of those cells in heart failure due to poor circulation resulting in a heart attack, or cardiac ischemia as it's called. In a 3rd trial, we'll soon begin also testing the possibility of other donor bone marrow cells, not from one's own body, but from other healthy donors, to treat heart failure due to chemotherapy. Now this is a picture of the adipose stem cells that are found on the small blood vessels of the heart. And this picture and the surrounding data around it were first published in an article by Dmitry Traktuev that many of you may have come to hear about and know, who works very closely with me at our center. And as you can see, and I'm marking here with our arrow, there is the red stained cell that is actually the adipose stem cell that is essentially wrapping its arms around and on the endothelial cells, that is the green cells that line that very small blood vessel, here stained in human fat. You can imagine how that red cell is specifically interacting with those green cells that are lining the blood vessel to support it, both from a chemical perspective as well as from a mechanical perspective. We like to think of those stem cells, which are abundantly available in one's own fat and can easily be obtained by liposuction, as the repair stations of the highways of the body, which are the blood vessels. And just like repair stations in general, they don't typically pick up and move along the highways. Instead, very typically, they are at a particular place on the roadside, and you bring to it whatever needs to be repaired. Well, what we have found is that that normal repair function of that repair station is carefully controlled by their location, so that essentially the toolboxes are closed, or the front door can be thought of as locked, until there is a need for repair, at which point the toolboxes then open, the door of the repair station opens, those tools become available, which are called the proteins, the RNAs, some of the other things that the cells can secrete, and we'll talk more about that in a while. When we take those cells from the adipose tissue, from the fat tissue, what we're doing is we're taking the tools that the repair stations have, we're unlocking the doors, and then we're providing them to the areas of the body that need them. And that's why it's so helpful to take those cells, use the tools, because that's what they normally do. They, in fact, are normally involved in repair in the body. We're not asking them to do anything different than what they do normally, except we're giving them the opportunity to do it in a more active and robust way. That explains why these stem cells derived from fat can actually address so many disease areas, because those repair stations are not only on the blood vessels in the fat, but also they're found in the blood vessels throughout the entire body. And that explains probably why they can address so many disease areas. Here I have a picture showing a series of thought processes and the sequence by which we began to address certain disease areas in the human body by beginning with animal experiments typically and with dreams. And as we move from those ideas and animal experiments into the human translation, I show here a series of dates. When the first date represents when the dream was conceived, we began with thinking about salvage of legs from a threatened amputation way back in 2001 and 2002. And then the second date refers to when our first article in that area was published. In that case, it was 2004. Some of our most recent articles have involved retinopathy and treatment of diabetes in 2014, as well as the treatment of ALS, Lou Gehrig's disease, which looks very promising with cell-based therapies based on the adipose-derived stem cells, and that we just had published in Nature Scientific Reports in 2015. So you can see some of them have X's at the end. That's because we're still in the process of doing the work and the publication hasn't come forward yet. But when one asks, how can this one cell type be so effective in all these areas, the general theme is we think that effectiveness is because that is what the cells normally do. That is repair in many areas of the body. Now here we show a diagram of injections in the leg for what we call the PACE study, and that is the study that the NIH has been supporting, as I mentioned, for pain in the legs that occurs with walking. Multiple injections into the legs, into the leg muscles that occur of a particular variety called ALDH cells from one's own bone marrow. We were privileged to be the first center in the CCTRN, first center in the country to enroll in this trial in June 2013. And in fact, the trial just completed very recently in terms of recruiting the patients, and again, we were very thankful to actually be the national leader here at the center in the recruitment under the CCTRN. Many other institutions participating importantly, obviously, to that recruitment effort as well. We will know in the next year or so the extent to which those cells may have been beneficial to those patients, because the trial design included patients who received the cell type that we're thinking may be positively helpful and others who received a placebo. So it was randomized, and we'll be looking forward to see those results. We also expect to begin to enroll our very first heart failure patients in summer 2016 in the two trials that I mentioned. One is called CONCERT, which refers to a combination of the cells from the bone marrow called mesenchymal or mesenchymal, and c-KIT positive cells, the cardiac stem cells. And this trial will look at either of those cells individually, or the combination of the two cell types, or finally no cells at all. So 4 different categories of patient will be treated, or 4 categories of treatments, I should say. Cell 1, cell 2, cells 1 plus 2, or no cells at all. And at the end of this trial, after a couple of years, we'll be looking to see which of the populations of patients have done the best. The other trial is called Seneca. It involves the injection of the allogeneic, meaning from other individuals, mesenchymal stem cell type in, as I mentioned, cancer survivors who have cardiomyopathy, heart failure, as a result of the chemotherapy that they've received, not specifically as a result of large blood vessel blockages. This relates to some diabetes research that many of you may have seen a bit about before. We published this with collaborators on campus, Tatsu Kono, who was on our training grant at one point, the NIH training grant, and Dr. Evans Molina, showing here diabetes work in which mice are made diabetic, and as a consequence of that diabetes, due to inflammation in their islets, their blood glucose, shown here on the y-axis, markedly is increased to this level, nearly the 400 level, compared to the normal levels, just about 200 over time following a meal. So they are given sugar here basically at the beginning, and then their sugar level goes up, as it does in people as well, and comes right back down into a reasonable range in those mice which are not diabetic. In those which are diabetic, as you see, there are 2 curves here. They basically lay over one over the other, red and blue. Neither has been treated at this stage, but they're both diabetic. However, after a single injection of adipose stem cells, if you look 7 to 10 days later, the mice which were not treated with those cells, here in blue, continue to be diabetic and in fact are even worse, whereas those which were treated with the cells in a single intravenous injection have improved significantly, more than halfway towards normal. And that effect, where those which receive the cell therapy are improved comparatively in their blood glucose, is persistent even out to 25 days, almost a month. So now we're looking for extending these data, obtaining additional funding in order to look at repetitive dosing, how long the effect persists, and whether in fact we can see the same sorts of effects with the materials that the cells secrete as well as just the cells. Here is another very interesting area of data that I think you may have seen something about before in other presentations. We've been very excited to see that the adipose stem cells also are very effective at blocking development of emphysema in mice. This is cigarette smoke-induced emphysema, and here we see a normal lung in cross-section under a microscope. Here we see how it looks very poor after cigarette smoke has certainly abolished many of the walls within the lung called the alveoli, and so it's gotten much more sparse. However, even after that 4 months of cigarette smoking, with repetitive injections of ASCs intravenously, the stem cells, the lung is virtually indistinguishable from normal. And that quantifies in terms of the length or distance between the branch points of the lungs, which is increased in emphysema in those who smoke, but with those who smoke and receive the cells, we're able to see a restoration towards normal. It's a very labor-intensive model. As many of you know, and I've spoken about before, we do have to train the mice to roll these tiny little cigarettes and then to proceed to smoke. And so, as you can see, it's quite an endeavor to conduct this model. We're certainly hoping that this will lead to a similar result when these cells are administered in people who have the severe disease of COPD or emphysema. Pancreatitis, another important area. This is a really big deal in terms of hospitalizations. It's in fact the single most frequent gastrointestinal cause of hospital admissions in the United States. Some is caused by gallstones, some is not caused by gallstones. It can occur in the context of high triglycerides, of diabetes itself, of alcohol abuse, quite a few areas that can cause pancreatitis, but we have nothing to offer for it medically. Current treatment is really limited to supportive care, not taking anything by mouth, and being on fluids and with a large amount of pain control, and sometimes it can even lead to pancreatic cancer. We recognize that macrophages play an important role in the progression and extension of this pancreatic inflammation. Macrophage is a kind of white blood cell. They also involve or get involved with the T cells and neutrophils, other white blood cells involved in pancreatic inflammation, destruction, and pain. And we hypothesized that the adipose stem cell could serve to limit the inflammation of the macrophage and the other cell types that ultimately degrade the pancreas. Here's a little pictorial of that. The adipose stem cell shown here as the blue cell, ASC, actually takes a macrophage which is now known to be a more inflammatory destructive type of macrophage called the M1 and can convert it towards an anti-inflammatory or repair type macrophage called M2 recently. This anti-inflammatory conversion experience, as it were, shown here in an artistic rendering, as it were, is mediated by those cells and what they secrete. Here we see some histological evidence in which a sham control, that is a normal pancreas, is shown here. Once one administers cerealine, which is a drug that actually increases the degree of pancreatitis or brings on pancreatitis, you see a lot of fibrosis, a lot of destruction of the pancreas shown here. However, in the case of treatment with ASCs, the adipose stem cells, we see that is significantly reduced, maintaining what appears to be a very close to normal or much more normal appearance of the pancreas. Now, we recognize lately, over the last quite a few years, that a lot of what the cells do to work on these various reductions of inflammation and help in a variety of ways is occurs because the factors, the stem cells themselves, secrete these factors. I referred to these before as the tools within their toolbox. Those factors here, shown as these little balls or bubbles, can conduct angiogenesis, that is growing vessels, neurogenesis, production of more neural growth and neural stem cell growth, a decrease in apoptosis or cell death, and a decrease in inflammation. Each one of these kinds of effects are mediated by these factors that can work at a distance to affect and improve the injured cell survival and ultimately regeneration. And what we found very recently, our group and many others in the field are now pursuing this as well, that exosomes, these are little factor-releasing capsules, are in fact released by the stem cells themselves. And the capsules here, shown literally as capsules, contain all these different colors representing different types of factors, different proteins, different peptides, even different RNA. And you can see all these little balls representing those factors that are contained in these capsules that emerge and are secreted by the cells as these effective agents to go to other cells and conduct these various reparative processes. So we can sort of think about the adipose stem cell as a bottle full of the capsules. It releases these capsules, the exosomes, that in turn release these various factors that are shown here represented by various colored balls that are effective to help the cells. The exosomes themselves, these capsules, are very small. This is actually a slide to scale showing the approximate size of an adipose-derived stem cell, much like the other stem cells. That's the repair station. And here you see the size in the little blue balls of the various capsules, the exosomes, and I've lined up more than 100 of them here right across the top just to show you in this yellow area how small those capsules are, and therefore they can easily move around and get to the areas that are interesting to target. Some time ago we began to look at whether a preparation of the exosomes themselves without the stem cells being included, but just what the cells secrete, could reduce the damage due to stroke. And here we see reduction of the damage due to stroke. This is the cross-section of a rat brain without a stroke. Here we see dramatic loss of neurons with a stroke on one side of the brain. Here we see dramatic protection when we provide those exosomes, those capsules that the cells secrete without the cells, but provide them intravenously, even as long as 36 hours after the stroke. There's a very significant protection structurally, and the animals that are involved in this also functionally and behaviorally are markedly better as to memory and their activity, even out to 1 or 2 months later. In a similar way, we've conducted experiments with collaborators. In each one of these instances, a different set of collaborators on campus. We're very grateful to work together with them. Here we show preparation of exosomes from adipose stem cells protecting the kidneys. In the case of kidney damage due to poor blood flow, this is creatinine looking at the extent of kidney function. The lower it is, the better, because this is, if you will, a toxin that the kidneys have to get rid of from the body. So you want it to be low. Pre or prior to the ischemia or poor blood flow experience of the kidneys were low. However, upon the onset of ischemia 24 hours later, this toxin is much higher, but if we provided the exosomes shown in the green, it's much lower. So that's a protection of the kidneys there. Here we have a remarkable finding we had the opportunity to publish also with our collaborator Yansheng Du, who also did the stroke work with us, and this was published just earlier in the last year, showing that the preparation of exosomes from the adipose stem cells is able to increase survival by doubling survival from the time of onset of symptoms in ALS or Lou Gehrig's disease in mice that have this type of disease. This mouse disease that parallels the humans is due to a genetic abnormality, and you can see that from the time of onset of muscular strength diminishing, which is about when they're 100 days old, because everything goes faster in mice, when they're not treated in a particular way other than just with basically salt water or control, they're dying here, shown here as a percent survival going down, but that mortality is abated so that the mice live about twice as long if they receive the exosome preparation on a frequent basis. Also, with our colleague Natalia Bogacheva, We show here the preparation of exosomes from adipose stem cells protecting the lungs. Here we show normal lung. We show lung that has what's called acute lung injury, which is similar to the kind of injury that occur in lungs not only after severe infections, but also in the context of severe disease or trauma, pancreatitis, various accidents, various large surgeries. There's an inflammatory process in the lung shown here in the middle panel, but upon provision of the exosomes from the adipose stem cells, even without the cells, that inflammation is markedly reduced. So now I've shown you several of the areas that we hope to bring into the clinic over the next couple of years. I'd like to talk now about leg disease. This is the area where we've moved the adipose stem cells into the clinic, as I mentioned just recently. And this was the first slide that was actually created in 2001, exactly as it was back then, except for the red line that says created in 2001. We dreamed that hopefully a patient with critical limb ischemia could be presenting to the vascular lab, and they might have a revascularization, but that they would be able to receive a liposuction under local anesthesia, that there would be a simple preparation of cells that would then be reinfused either into their leg or their system to assist in revascularization. There are quite a few ways now that this can be done. Just as there are multiple ways to make coffee at home, Keurig and other various coffee makers shown here, there are now several ways to make what we call the stromal vascular fraction at the bedside. So I like to call it the cappuccino machine that takes fat and turns it within about 90 minutes or less into a stem cell preparation that comes out just like the coffee comes out of the cappuccino machine. This is a particular device with colleagues of ours in tissue genesis that are able to collect and process the adipose-derived cells with a target time less than 90 minutes. It's actually closer to 70 minutes. And this was actually just a series of slides about our very first case. Here we have our plastic surgery collaborator, Dr. Haddad, and here describing the first patient to receive this treatment. He was walking typically less than 20 feet due to leg pain. In fact, when I've met him in the hospital prior to the procedure, he had been rolled in a wheelchair, and asking what he would hope to be able to do, he was hoping just to do some things like attending his grandson's ball games, soccer games, do some mushroom hunting, things of that nature, which had been impossible for quite a few months because he was awakening every night with pain 8 to 10 times, despite using opiates for his pain control at a very high dose. So here we see a machine monitoring the suction of a fat harvest. Here we see filtering the harvested fat, obtaining syringes of fat, and this is just under a local anesthesia with moderate sedation. It's not under general anesthesia. Receiving that fat from the area of his abdomen. This is the syringes of fat, and then being handed off to go off to this cappuccino machine, as we call it, the processing machine. And here we see our colleague, Paul Kosnick, a very close colleague in that particular company that we've been very grateful to work with, and he's happy here because we've been able to show that that machine yielded a preparation of living cells, a good harvest number-wise, that is similar to that which we can do with a technician under the hood in the lab, but here it's done in a way where it's all very clinically maintained in a sterile environment without ever having to uncap and recap repetitively the various tubes that are involved. Here Dr. Haddad is injecting cells into the marked areas of the leg. And the morning after, looking at the leg here without bruising, you can also see there's the area shown along the leg where the bypass surgeries that had been done before actually had repetitively been breaking down and causing wounds that were hard to heal. Very grateful to see in this very first case, and this has now been seen in terms of other cases as well, that this patient was able now to walk 1/2 mile twice daily. During Christmas shopping, in fact, was able to walk an unprecedented 2.5 miles, is awakening at night much less frequently with pain, 1 to 2 times typically, is much less sleepy, feeling better throughout the day, and the family certainly reports that he's much less grumpy and happier as a result of this. He's off all opiates for pain control, and in fact was even able to go on a family trip to Florida where they walked 1/2 mile on a pier, stopping only a couple times. Now, this is remarkable. You can, of course, recognize this is in the first case here. It's the first case. It's one story. It's an anecdote, as one might say. But very importantly, the nighttime ability to sleep and be off medications, I think, is not easy to explain as, say, just a placebo effect. That's clearly an effect on the painful nature of the inflammation. So we would say now that the future is now as far as the possibility to use the adipose-derived stem cells obtained from liposuction under a circumstance to substantially improve the leg and hopefully prevent the need for an amputation. As I've mentioned, alluded to, some of the programs for our growth in the next year ahead will be diabetic eye and kidney disease, pancreatitis, even kinds of neurological inflammation, including ALS. I did not have a chance to talk about the work that we hope to be able to do and have early data on in traumatic brain injury or concussion, Alzheimer's as well, in the preclinical area, so all of those in the animal area, and we're moving towards clinical work now, hopefully this coming year, with heart failure, with osteoarthritis, and with ALS. I certainly want to thank our entire team and collaborators, the ones who worked very closely with me, both shown in white, as well as various faculty members who have been close collaborators at one time or another over the last more than a decade, shown in blue. Some others that are now in other institutions, shown on the side here, both in this country and in other countries, including the Czech Republic and Norway. And I always like to say Dr. Future in case there's anyone watching this presentation that would like to join us. And once again, I want to thank you all very much for your support and for listening to this presentation. I hope that this helps you to be able to think about the possibilities with stem cells and what they secrete that will help your family, your friends, and many other people around the world over the years to come. Thank you so much. Bye.